Hello and welcome to your Advanced Therapeutic IV Management audio lecture. This audio lecture will cover central venous catheters, IV therapies, blood administration, and heparin infusion. All of these types of solutions have to do with osmotic pressure. That is the pressure that develops when two solutions of different concentrations are separated by a semi-permeable membrane. Osmotic pressure varies with concentration of the solution and with temperature increased. We have an osmotic pressure approximately equal to that of the circulating fluid, which is the blood. Solutions exerting this osmotic pressure are isotonic. Weaker solutions that cause cells to swell are hypotonic. Stronger solutions that cause cells to shrink are hypertonic. Plasma expanders are slightly different types of solutions. These help to reestablish intravascular volume by increasing the oncotic pressure in the intravascular space. So I mentioned that plasma expanders are a little different type of solution. They increase oncotic pressure. So basically it is a type of IV therapy that provides volume for the circulatory system. The table on the right provides information on the exact difference between osmotic pressure and oncotic pressure. We will take a look at these different solutions as we move along. Hartmann's is made from natural sources of starch. It increases the volume of blood plasma that can be lost through bleeding or severe injury. There are a number of scenarios in which fluid resuscitation is necessary. Most commonly, you will see this need in instances of trauma, burns, sepsis, or hypovolemic shock. Plasma volume expanders, such as crystalloids, colloids, or a mixture of both, are used to do the following: restore vascular volume, stabilize circulatory hemodynamics, and maintain tissue perfusion. Also, the initial goal is to stop the volume loss and then restore the circulating volume. This slide gives you some guidance as to the benefits and drawbacks of crystalloids versus colloid solutions. Plasma volume expanders, whether they're either crystalloids or colloids, attempt to reestablish intravascular volume by increasing the oncotic pressure in the intravascular space. Moving into this conversation, understand that current medical and nursing research continues to demonstrate very little difference in overall mortality in patients who receive one or the other during episodes of hypovolemia. Keep in mind that any loss of circulating volume will cause a reduction in venous return, leading to a decrease in stretch of ventricular muscle. So what this means is that your patient will have the following: a reduction in cardiac output. Remember, that's the amount of blood the heart ejects in liters per minute. They will also have a decrease in stroke volume. Stroke volume is the amount of blood ejected by the left ventricle in one contraction. Thus is 1 milliliter per beat. Normal is 1 cc per kilogram. And also a decrease in blood pressure, urinary output, and capillary perfusion. Looking at crystalloids, during the process of hypovolemia, volume has not only decreased in the intravascular space, but also extracellular water moves into the intravascular space. You may be using a crystalloid solution with less sodium so that fluid will actually be distributed more evenly throughout total body water. Hypoxia can be a detrimental issue after resuscitation because crystalloids can adversely affect the microcirculatory blood flow and oxygenation. The primary disadvantage of using a crystalloid solution is the risk of causing peripheral and pulmonary edema. Colloids tend to have a high tendency to stay in the intravascular area. Colloid solutions have large molecules and are retained more effectively in the intravascular space, therefore may be beneficial in increasing circulatory volume. It will take longer to develop pulmonary edema with the use of colloids. However, it is more persistent. So when we compare the two, it is believed that beneficial action of colloids occurs faster. Crystalloid solutions have shown to have a similar positive effect for promoting volume replacement. So a patient example would be if a patient had a large protein loss, such as a burn patient, they would have colloids, and colloids are very expensive. Isotonic solutions are solutions that have a concentration of electrolytes, non-electrolytes, or both, that will exert osmotic pressure equivalent to that of the solution with which they are being compared. Isotonic fluids are ordered for the purpose of the following: replacing water loss and treating hypernatremia. The provider would order D5W, so 5% dextrose in water. Another purpose would be to expand intravascular volume and replace extracellular fluid losses. In that scenario, the provider would order 0.9% normal saline. That would most likely occur with a patient with dehydration, such as diarrhea and vomiting, or surgery due to blood loss. Another purpose for isotonic fluids would be to provide sodium chloride and free water. The provider would order 5% dextrose in 0.225% of saline. Another purpose would be to expand intravascular volume and replace extracellular fluid losses. So fluid losses from burns and lower GI. LR would be the fluid of choice. Hartmann's IV infusion compound contains sodium lactate, sodium chloride, potassium chloride, and calcium, often equated with LR. It is especially suitable when the losses result in acidotic conditions. These are solutions that have an osmotic pressure less than that of cells or body fluids. It's a solution that will cause water to enter cells, thus inducing swelling and possible lysis. This solution has more water than electrolytes. Hypertonic solutions are solutions that have a greater osmotic pressure than that of cells or body fluids. This is a solution that draws water out of cells, thus inducing plasmolysis. And plasmolysis is shrinking of cytoplasm in a living cell caused by loss of water by osmosis. Hypertonic solutions must be administered slowly and with caution. They have the potential to cause fluid volume overload and pulmonary edema. It's used for the treatment of symptomatic hyponatremia. So we would give them 3% of normal saline. In addition, these solutions provide some caloric intake. Remember that crystalloids are like a crystal. They are a substance capable of crystallization. When in solution, can be diffused through or pass through semi-permeable membranes. This is what distinguishes them from colloid substances which cannot do so. Often, crystalloid solutions are used initially in shock resuscitation. About 2/3 of this volume will diffuse out into the interstitial space from the vascular space. LR should be used cautiously because a taxed liver may not effectively convert the lactate to bicarbonate, leading to increased serum lactate levels. So again, a patient with decreased blood pressure, increased heart rate, and has edema, which was third spacing, they would have an isotonic crystalloid for treatment. Colloid solutions are substances used as plasma expanders initially or in phase of blood. Colloid molecular size allows for them to remain in the vascular spaces for longer periods of time. Choice of volume expanders is determined by the type and volume of blood loss with which you are dealing. Somewhat different nursing implications exist for each of these substances listed. 1. Plasma or human albumin. Monitor for circulatory overload. They're more expensive than other colloids. Number 2 is dextran. Dextran increases the potential for bleeding because it may cause a reduction in platelet adhesion and a dilution of clotting factors. Allergic reactions and acute renal failure are also potential complications. Number 3 with hetastarch can be up to 50% less costs than that of human albumin. It must be used cautiously in patients with CHF, renal failure, or bleeding disorders. Again, it's due to its anticoagulant effect. And last, plasma protein fraction. It is a solution of particular proteins removed from blood plasma used to increase blood volume. This slide should look familiar to you. We're going to transition into safe medication administration. You are always using two means to identify your patient: asking the patient, looking at the armband, and barcode system. You never identify a patient by room number, ever. Look at the label on the medication, as well as the medication name on the order, generic versus trade name. You are looking at the medication order to confirm the dosage. It is appropriate dose, and do you need to recalculate for confirmation? Is the route appropriate for the medication, dosage, frequency, and so forth? Never give a med if it is not labeled. Always provide hand hygiene prior to preparing meds. Always check your labs prior to giving them meds, as well as assessing your patients. Always assess your patients. Always, always, always. Look at frequency. Are you administering at the prescribed time? Don't forget to look at when the last dose was given. Was it late? Was it early or not at all? For documentation, remember that you always document after you give the medication, not before. So never chart before. Even if you're trying to save time, it's illegal. Also include the site of an injection or any laboratory value or vital sign that needs to be checked before giving the drug. Reevaluate the basis for ordering this medication in the first place. What is the patient's history or diagnosis? As the nurse, you need to understand the provider orders. It's not just because that is what the provider has ordered. You have to understand the whys. This is also a good time to think about your patient's long-term use of the medication. Is there a problem with time? Finally, is the drug producing the desired effect? This involves assessment and evaluation. If it is an antihypertensive, is it working? Has the pressure stayed within normal limits? Is the heparin producing the desired effect on your patient's clotting times? Is the insulin drip that you've started, is it maintaining an appropriate blood sugar level? Are the undesired side effects that your patient is experiencing? Again, you're looking at all those different things. Let's take a moment to look at dilution and reconstitution of medications. Do you know the difference? Dilution is weakening of a substance. Usually it's normal saline or sodium chloride or sterile water for injection. However, you're always going to check in your drug guides as far as if the medication has to be diluted and with what. It'll tell you that in the drug guide. Reconstitution is returning a substance previously altered for preservation and storage to its original state. Always read accompanying literature with medications. Extreme cost consciousness has overtaken the healthcare system. Nurses are being requested not to dilute drugs unless specifically required by the manufacturer to save the cost of needles, syringes, vials, and diluent. Label with the amount and type of diluent and strength of the concentration. Remember, you always need to label accurately. Remember that triangle method that has been taught to you since Block 1. Labeling IV medications is very important for patient safety. You should label your bags with the current solution and rate of administration, as well as any medications that are added and the dose of the medication. Again, if you're adding any types of medications, you would include the dose. But most likely, from pharmacy, they've already mixed everything for you. This is only if you're adding something to it. You would include the time and the date, your initials, and the expiration date, and syringes if applicable. Drip chambers. So on this slide, we have micro drip chamber and macro drip chamber. There is a significant difference between a micro drip and a macro drip IV tubing. Always check the packaging to obtain specific drip rates, but the numbers here are what you will find. And they make a considerable difference in how you will compute the accurate drip rate. Buretrols. Buretrols were used before IV pumps to limit the amount of fluid a patient could receive. But now we have pumps, but back we did have buretrols before IV pumps, and this is a picture of what it looks like. All right, intermittent infusions. IV infusions may be given through a saline and or heparin lock, meaning that patient is not connected to any running fluids. They're saline or heparin locked. They also are consistent of piggybacked to a continuous IV infusion or for long-term therapy through a venous access device. Those are intermittent infusions. Central venous catheters. All right, so let's start by looking at central venous catheters. A CVC or central venous catheter can be a number of catheter types, but all have one thing in common. The distal tip of the catheter rests in the central vasculature. There are 4 basic types: PICC, non-tunneled, tunneled, and implanted port. A PICC is a peripherally inserted central catheter. The point of insertion is usually the upper arm, and the distal end usually ends up in the distal 1/3 portion of the superior vena cava. A PICC is inserted by a specially trained and certified PICC nurse specialist. Generally, a PICC line can be used for up to 6 months. They are utilized for long-term fluid administration, blood infusion or draws, and intermittent or continuous drug infusions such as antibiotics or chemotherapy. This diagram just gives you an idea of PICC placement. When you see that green area on this patient's arm, that is where the pick has been inserted. If you follow along that black line there, then that goes into the third part of the superior vena cava. Non-tunnel catheters are placed percutaneously, so through the skin. They're placed directly into the vessel, near the neck, chest, or groin. They are sutured at the point of insertion, and they are to be used for temporary access, so typically less than a couple of weeks. Examples of non-tunneled CVCs are subclavian, jugular, and femoral lines. Tunneled catheters are inserted by a doctor in the surgical setting. They can be kept in place for several years, so long-term use. The catheters have a distal and proximal cuff. The proximal cuff is at the skin side and has antimicrobial properties. The distal cuff anchors the catheter in place. The distal catheter tip is advanced into the vessel and placed in the superior vena cava, while the proximal end is subcutaneously tunneled to an incision exit site on the anterior trunk of the body. Advantages include the ability for longer use and a decreased risk of infection due to the distance between the venotomy and the skin entry site. These are all types of tunneled catheters. Groschons are unique due to a valve on the distal end of the catheter that is pressure sensitive. It allows fluids to flow in or out but stays closed when not in use. It reduces the need for clamping. The valve restricts backflow of blood into the catheter, thereby decreasing the chance of blood clots. And it reduces the occurrence of air embolism. A Hickman or Broviac are examples of tunnel catheters. Again, they are placed in the OR or in interventional radiology. Or if a doctor inserted it into the ICU, it is not tunneled. Nurses do not remove these. Again, nurses do not remove these. When you look at a tunnel catheter, it doesn't have the wings that are used for sutures. Also, you can feel a bump an inch or two away from where the catheter comes out. This is the cuff, a piece of material that grows into the tissue to keep microbes out. Portacasts are also known as vascular access ports. They are also inserted by physicians in the OR setting. A small chamber is placed in a subcutaneous pocket. Then the line is threaded into the superior vena cava. When this port is not being used, it can be felt but not seen. Advantages of an implanted port include the following: less interference with activities of daily living, they require less flushing, and the risk of infection is reduced. A special needle, which is called a Huber needle, is required to access the device. This then must be anchored to the skin. These ports may be single or double injection ports. Implanted ports are to be accessed by non-coring needles only. The use of standard blunt angle needles can lead to deterioration of the port, carrying with it the potential for embolization of port materials. So on this side, you can see the difference between non-coring, which is the Huber, and coring or standard needles. A skilled provider must be the one inserting the line and managing the insertion process. A timeout must be performed. The Joint Commission has stated that this must include verification of the correct patient, correct site, and correct procedure. Proper hand hygiene must occur. Appropriate attire is required for insertion of a CVC or central venous catheter. The site is then prepped with chlorhexidine and allowed to air dry. When you drape your patient, be sure to use sterile procedure. The line is then inserted using sterile technique. After the line is inserted, clean the site again with chlorhexidine and cover the insertion site with a sterile occlusive dressing. When you think of optimal catheter site selection, know that the CDC recommends the subclavian vein for cannulation. So try to avoid the femoral vein and jugular vein if possible. Why? Due to the movement, dressing securing problems, and increased risk of infection. An assessment of the line on a daily basis is always required to determine site condition, functionality, and need. Remove immediately if not needed. Confirmation of accurate location comes from the physician following interpretation of imaging and/or an ABG sampling. The tip should rest in the distal 1/3 portion of the superior vena cava, right atrium, or pulmonary artery. So confirmation is to make sure that you check X-ray or EKG prior to use. You should be checking the hospital policy for confirmation. Several basic steps are included in a central venous catheter flushing. Always identify the type of catheter in place. Alcohol is a required prep solution. Scrub for at least 30 seconds. If you use less than a 10 cc syringe, there is a great risk of causing too much pressure on the catheter itself and could cause harm. You should always exert minimal force to activate the flush. Remember this, the initial flush is a pulsatile flush, meaning we use a push-pause method. We push and then we pause. Push, pause. Always document this care on the prescribed order sheet. This is information from the CDC. Note that these infections independently increase hospital costs and length of stay, but have not generally been shown to independently increase mortality. While 80,000 cases of central-related bloodstream infections occur in ICUs each year, a total of 250,000 cases of bloodstream infections have been estimated to occur annually if entire hospitals are assessed. Central venous catheter line risks. This is very important to know. This is a very important slide to be very made aware of. Air embolism. Air bubbles may enter the blood vessel during insertion of a CVC. This may produce symptoms such as decreased blood pressure, lightheadedness, confusion, increased heart rate, anxiety, chest pain, or shortness of breath. Next is infection. It is impossible for an infection to develop either inside the vessel or surrounding the insertion site where the catheter enters the vein. The symptoms include fever, chills, tachycardia, fatigue, muscle aches, weakness, decreased blood pressure, redness, swelling, or purulent drainage at site, or elevated white blood cell count. Phlebitis. Phlebitis is an inflammation of the vein where the catheter is inserted. The symptoms include redness, pain at access site, streak formation, palpable venous cord, or purulent drainage. Catheter malposition Malposition can occur during CVC insertion or later due to changes in pressure inside the chest or from catheter migration. After the insertion of catheter, the position of its tip is confirmed via X-ray. Confirmation of proper tip placement is required before using the device, as a malpositioned catheter can cause serious complications. Securing the CVC catheter is also essential to help prevent catheter dislodgement or migration. Sutures should not be used to secure the catheter to the site, as these can lead to complications such as an infection at the site or catheter related bloodstream infections. Pneumothorax/hemothorax. Either a pneumothorax or hemothorax is a risk factor. Basically, air enters the pleural space. You may also have blood that enters as well as a result of vessel injury. Pneumothorax is one of the most frequent mechanical complications during a CVC insertion. So basically, if your patient develops shortness of breath and becomes restless, that's serious, and you need to assess your patient, and you would be listening to their lungs. Thrombus formation. Any catheter inserted into the vascular system increases the risk of thrombus formation, either in the vessel or in the catheter. Difficult removal. There may be resistance when removing the catheter, and this may occur at any time during the process. Nerve injury or irritation. During insertion of the catheter, nearby nerves may get injured or irritated, producing symptoms such as a shooting type of pain down the arm, numbness, tingling, pins and needles effect, weakness of extremity, or paralysis. Leakage. Leakage occasionally occurs at the insertion site. This may be caused by the loss of elasticity of the skin at the site, outward migration of the catheter, or rupture of the catheter. Catheter breakage. Rarely, catheter damage can occur, and most often it is from improper care. It may occur due to improper anchoring, using a syringe that is less than 10 mLs. Remember, you have to use at least a 10 ml syringe, and or from applying excess pressure when flushing the device. If the catheter is placed in the elbow bend, breakage can also occur from repetitive motion, which should be avoided. Dialysis catheters are not to be opened, flushed, or used by non-dialysis nurses. As a non-dialysis RN, you may access these only after a physician order is obtained and a hospital policy allows you to do so. Renal dialysis catheters are locked with 5,000 units per 1 ml of heparin for each lumen. The physician will order the specific volume and amount of heparin to be used in each flush. All dressing changes must be done by dialysis-trained nurses only. Dialysis catheters should only be removed by nurses trained to do so, such as ICU and dialysis registered nurses. Packed red blood cells, or PRBCs, will have a volume around 330 cc's and a hematocrit of 50 to 70%. This is the type you will use predominantly for severe hemorrhage, symptomatic anemias, perioperatively, and in sepsis. Plasma will often be ordered in patients who are experiencing coagulation abnormalities as a result of severe hepatic disease. Patients with DIC, which is disseminated intravascular coagulation, and sometimes for the reversal of the effects of Coumadin, in which they would have an elevated PT-INR. Platelets can be used as a prophylactic intervention in bone marrow failure, bleeding that occurs with thrombocytopenia, after radiation or chemo, and platelets are often therapeutic for bleeding. Albumin will be used frequently in the case of hemorrhagic or traumatic shock and in burn patients. It is a volume expander used when crystalloid solutions are not adequate. This slide here shows you relationships between blood types and antibodies. Again, you can review this slide here. When administering blood products, it is so important to verify and document patient identification. During blood administration process, it takes 2 RNs to administer blood products. For all of these reactions, you will first stop the transfusion and immediately notify the provider. For a hemolytic reaction, you will also monitor and maintain blood pressure. A febrile, non-hemolytic reaction requires that you monitor vital signs, maybe administer an antipyretic, and then you may actually restart the transfusion very slowly. Again, you will stop the transfusion for an allergic reaction. You will monitor vital signs, maybe give an antihistamine, and then restart the transfusion at a slower infusion rate. Circulatory overload will require careful monitoring of vital signs, elevation of the head of bed, and maybe administer a diuretic as well. We would be looking as nurses for signs and symptoms of fluid volume overload. Blood administration. Before the blood is acquired from the lab, you need the patient's informed consent, and then it is placed in the patient chart. You will need to check the provider order. It should contain type of blood, number of units, and flow rate or duration rate. As the nurse, you will need to then have adequate IV access and supplies available. Verification of blood products that matches the order, the patient name, the medical record number, and expiration date. Immediately before you start the transfusion, you need to assess your patient, their vital signs, and respiratory status. Very close observation is required during the transfusion. Most reactions will occur within the first 15 minutes. You will monitor your patient every 5 minutes for 15 minutes, then at least every hour thereafter. Why do we use saline as a secondary IV solution? Because it does not cause coagulation. LR is not used because it contains calcium, which would cause clotting. So again, we use normal saline. Anticoagulation therapy does not decrease the clot, but it does keep clots from getting bigger. And it reduces the opportunities to form new clots. So it is very effective in managing and preventing further development of clots in patients presenting with DVTs, pulmonary embolisms, and MIs. Normally, patients are started on IV heparin with a bolus, followed by a continuous drip. The dosage is based on your patient's weight. So we'll weigh them, heparin's a weight-based medication, so we will figure out our patient's weight in kilograms. Heparin therapy is monitored through APTT, done at the initiation of therapy, and then repeated every 4 to 6 hours. The therapeutic goal is 1.5 to 2.5 times the normal value. Once the APTT is in the therapeutic range for 2 consecutive draws, it is then drawn every 12 to 24 hours. Anticoagulation continues after discharge with warfarin, which is Coumadin. This will be monitored by INR results. The therapeutic goal is 2 to 3. Normally without heparin, it's 1.1. Patient-controlled analgesia, or a PCA, is a very effective method to assist patients in the control over their pain. The prescriber and the nurse play a role in the selection of patients who would benefit. The prescriber will determine the appropriate dose for that patient, and the task of patient education typically will be handed off to you, the nurse. Less desirable candidates might include the following: adults who are confused or who have developmental delays, those who are obese or asthmatic, individuals who are already taking medications that might potentiate opioids, patients with a diagnosis of sleep apnea, and known substance abusers. With regards to advantages of a PCA usage, research has consistently demonstrated that patients actually will use less medication. They are not required to wait for nursing personnel to arrive and deliver the dose. Patients report greater satisfaction, and patients are able to move more readily, take deep breaths, and ambulate earlier, thus reducing the risk of post-op complications. The PCA pump is initially set with preset intervals for pain medication delivery. Dose intervals permit self-administration of a dose of medication every 6 to 8 minutes, or until the first dose has had time to be effective. Once a patient has self-administered the doses assigned for the time period, the pump will not deliver another dose, even if the button is pushed. As the nurse, you must be familiar with risk factors that can increase respiratory depression. A patient who is extremely overweight or underweight. Number 2, medications the patient might be on that synergistically work with opioids. And last, with pre-existing conditions such as asthma and sleep apnea. I'll take a couple of minutes here to review the medications listed on this slide. Morphine is one of the most commonly used opiates because it is easy to titrate and offers multiple routes for admission. Keep in mind, though, that it may accumulate in patients with compromised renal function, extending sedation and respiratory depression. Fentanyl is a synthetic opioid. If you look at it milligram for milligram, it is 100 times more potent than morphine. Its onset is more rapid, but may have prolonged effects in our critically ill patients. Fentanyl does not cause a natural histamine release, so it may be beneficial if hypotension is a concern. Hydromorphone or Dilaudid is a semi-synthetic opioid that is 6 times more potent than morphine. It is likely to cause more sedation, less respiratory depression, and a decreased risk of physical dependence. There is little to no metabolic buildup of this drug, so may be a better choice if your patient is experiencing any level of renal compromise. Meperidine or Demerol is a semi-synthetic and mild opioid narcotic that poses similar narcotic-specific risks. Reversal agents are Narcan, Revex, and naltrexone. Both Revex and naltrexone have a longer half-life than Narcan, which is usually 8 to 12 hours. So if your patient develops any type of shortness of breath, least invasive first would have the patient cough and deep breathe and then medicate if your patient needed to have a reversal agent. Also remember with PCA pumps that if it's not managing your patient's pain, as the nurse, you would need to review the treatment protocol with the provider. Total parenteral nutrition, or TPN, requires a combination of major macronutrients, water, which is 30 to 40 milliliters per kilo per day, Carbohydrates are necessary for the energy requirements of the body. TPN is normally around 25% dextrose. Proteins or amino acids are a requisite for body growth, maintenance, and repair of tissues. Essential fatty acids, vitamins, and minerals, which are lipid emulsions, provide additional energy as fatty acids. Lipids are either a part of the primary TPN infusion or administered separately on a prescribed schedule. Basic TPN solutions are prepared using sterile techniques, usually in liter batches according to standard formulas. So normally 2 liters per day of the standard solution is needed. Solutions may be modified based on laboratory results, underlying disorders, hypermetabolism, or other factors. Most calories are supplied as carbohydrates. Typically about 4 to 5 milligrams per kilo per minute of dextrose is given. Standard solutions can contain up to about 25% dextrose, but the amount and concentration depends on other factors, such as metabolic needs and the proportion of caloric needs that are supplied by lipids. TPN may be the only feasible option for patients who do not have a functioning GI tract. Parenteral nutrition bypasses the digestive system. Patients that may require TPN have disorders such as needing complete bowel rest, so due to major illness, major surgery, trauma, or severe burns. The decision to begin parenteral nutrition and the timing of initiation varies. It requires patient examination, knowledge of nutrition assessment, appropriate indication for initiation, appropriate access device selection. You will have an established management protocol for the following: blood sugar monitoring. Remember that with parenteral nutrition, it has dextrose, so therefore we monitor their blood sugars. Also, assessing your patients for fluid volume overload. Remember, you need to know signs and symptoms of fluid volume overload when they are receiving TPN. Also, being aware of and reporting of daily labs, such as calcium, potassium, magnesium, and others. This concludes your audio lecture for CBC, IV therapies, blood administration, and heparin infusion.